very excited to be starting this webinar on ARV price reduction mechanisms. As part of global funded multi-country project sustainability of HIV services for key populations in Eastern Europe and Central Asia, of course, the issue of pricing for ARVs comes on very strongly in our agenda. I remember back 5 or 7 years ago, the World Bank published analysis on the prices that were paid globally for ARV medications. And unfortunately, Eastern Europe and Central Asia, with one of the worst HIV epidemics, was actually paying some of the world's highest prices for ARV medications. And it was very unfortunate because not only fewer people could access treatment in the region, but also the funding that was overpaid could not be used for diagnostics, for prevention, could not be used for PrEP. That's why, of course, the attention to the issue of pricing is very, very significant on our part. Many things have changed in the last 5-7 years, and I'm very pleased that the prices have gone tremendously down in the region. And we are very happy that the Economist Impact made an analysis of what has actually worked in the region to bring these prices down, because we are still not there to make sure that what we pay for ARVs is optimal. Therefore, a real pleasure to be presenting this webinar today, where we will hear from the policy brief developers, the Economist Impact, on what they have arrived at, what are some of the important learnings, and also hear from some of the colleagues who are key to reducing prices in the region, like the Medicines Patent Pool or Health Advocacy Coalition or the Global Fund, on what is being done now and what is working, or what we should be doing more. So you see the agenda on the screen, and we will be starting with it in a minute. Please do use the chat box or Q&A boxes to ask your questions. We will be responding to them as we go along the webinar, but also at the end, there will be some time for open discussion, and it would be great to hear some of your perspectives or reactions of what you have heard. So I will be stopping here, and I'm very pleased to invite Aanisah Khanzada from the Economist Impact to share the results of the analysis. What has worked in reducing ARV prices in Eastern Europe and Central Asia? Dear Aanisah, please, the floor is yours.
Thank you so much for your warm welcome, Tetiana. Let me just share my screen, and then I can get things rolling. Can everyone see my screen?
Yes, we can see a full screen.
Okay, great. Well, thank you once again for the warm welcome. So my name is Aanisah Khanzada, and I'm going to be presenting the results found across our research, looking at mechanisms used to reduce the price of ARVs in Eastern Europe and Central Asia. Now, before diving into the presentation, this is just the agenda for my talk today. So I'll be going through background, so context to the issue. I will be going through price reductions already achieved between 2018 and 2021. I'll be going through the price reduction mechanisms used across our countries of interest, and then I will conclude at the end. So just some background. So the Eastern European and Central Asian region is one of the fastest growing HIV rates in the world. So between 2010 and 2021, new HIV infections increased by 48%, and AIDS-related deaths increased by 32%. Now, many factors contribute to this growing epidemic, from discrimination towards HIV populations to high ART costs. Now, when we think about high ART costs, the region has a very high average price for ART across both first and second line compared to other regions, as you can see in this bar graph here below. And when we think about why the region has such high ART costs, it can come down to many things, from poor procurement processes, lack of transparency, and even a lack of competition for generic drugs. Now, this slide is just going through the progress made already with reduction. So on a whole, across all our countries of interest, the average price of ARV medicines has decreased, and between all our 5 countries, savings of 13 million USD were recorded. Now, Kyrgyzstan has had the most significant decrease, and Kazakhstan has had the smallest reduction, but nevertheless, they've all experienced some form of a reduction. If we talk about average cost of ARV treatment per patient, Ukraine has had the lowest cost, whilst Kazakhstan has the highest. Our report does explore the reason for Kazakhstan's high average cost, but just to reiterate, all our countries have experienced a decrease, and I will go into the reasons for that. So our first country of interest was Georgia. Now, Georgia has transitioned or is transitioning into an upper middle income country, and donor funding is set to decrease. Now, there is a pattern we're seeing across all of our countries of interest where there is a decrease in funding from donors, and it forces countries to kind of develop a self-sustained HIV response, as well as to, purchase ARVs using state funds. So for countries to really afford ARVs, the price must be low. In terms of market authorization in the country, only registered medicines can be purchased and manufactured, but there is a drug waiver which allows the country to skip that registration process and import non-registered ARVs. In terms of mechanisms used, we really saw that advocacy networks helped identify the overspend of ARVs, and the country also uses pooled procurement via the Global Fund. Our second country of interest was Kazakhstan. Now, Kazakhstan does pay a higher price compared to other countries, but like I said, it still experienced a decrease. Now, the country has transitioned to an upper middle income country, and donor funding has decreased. In terms of market authorization, it can take a while for WHO pre-qualified drugs to be registered. So unregistered drugs can be approved for import only on the condition that they have WHO pre-qualification in the source country that they're being imported from. In terms of price reduction mechanisms used, we found that civil society organizations have played a very major role in improving access to generic ARVs. So they were quite instrumental in getting the country to be included in the Medicine Patent Pool and VIV voluntary license for DTG. Now, I just want to note that all of our countries of interest in the research have access to this voluntary license, through which generic versions of the WHO recommended DTG can be purchased at low price. The country also has pooled procurement mechanisms via UNICEF to obtain cheap ARTs. Now, Kyrgyzstan was our third country of interest, and this country achieved a significant reduction. In terms of structure of funding, so they are a low and middle income country and they continue to receive donor support, but they are looking a way to transition towards state funding only. In terms of market authorization, it's very interesting because the country has undergone a few changes in their legislation which give them a lot of freedom around drug registration. So for example, in 2015, a patent law was amended which enabled the use of TRIPS flexibilities. And as a result of this, it created a very lucrative market for generic competition. But also in 2017, a new law came into the country known as the Circulation of Medicines. And this law kind of sought to improve the quality of medicines available and also to accelerate the registration process. But the law also grants some medicines an exemption from the registration process if they're used to treat illnesses that pose, I guess, a significant threat to the population, including HIV. In terms of price reduction mechanisms used, the country has a budget advocacy coalition, and because of this coalition, a greater proportion of the state budget has been allocated to health. The coalition has also improved the transparency of the procurement process of ARVs. For example, they conduct budget analysis and they also provide advice to the Ministry of Finance and Health. The country's also joined the Open Government Partnership, and this network exposes kind of price disparities across ARTs. The country also has generic competition, which is what I mentioned earlier, as a result of the amendment made to the patent law, but they're doing quite well in terms of different mechanisms being used. Now, Moldova is our fourth country of interest, and this country has transitioned away from Global Fund support. And in terms of market authorization, they have simplified the process a lot, which has been in their favor. In terms of price reduction mechanisms used, now again, civil society organizations have played a very, very key role in price reduction mechanisms because they've helped a lot with budget reforms in the country. And they've also been very instrumental in setting up an e-procurement system known as M-Tender. Now, this transparent procurement system basically allows for government information and public contracts to be accessed online. So essentially, ART prices can be tracked and cheaper alternatives can be sourced. Alongside budget advocacy and the M-Tender system, generic competition is also something that Moldova kind of uses as a reduction mechanism. Now, Ukraine was our last kind of country of interest, and it's a lower income country which still receives support from the Global Fund. But it's important for me to note that in 2020, the country did fund all of its ARV procurement with state funds, and no support was kind of obtained from international donors. But this does exclude non-government controlled regions, and these non-government controlled regions still continue to receive support from the Global Fund. In terms of market authorization, we found that some changes were made to the law of Ukraine regarding medicines, and these changes were around simplifying the registration process and also introducing patent opposition procedures. In terms of price reduction mechanisms, Ukraine has done quite well, and they've done a lot too. So again, civil society organizations have been at the forefront, and they've played a very key role in improving access to generic ARVs and a reduction in price. So they've been very key in setting up a e-procurement system known as ProZorro. So it's similar to M-Tender, where information can be accessed online in terms of contracts and tenders. But in addition to having this ProZorro procurement system, Transparency International Ukraine has developed a sort of analytical tool which allows the whole country to access medical procurement data and to compare ART prices to choose the cheapest one out of the ones that they have compared against. Ukraine has also created a state kind of procurement agency, and through this agency, a lot of savings have been generated, so total medicine savings, but this is not just across ARVs, but it's still important for me to mention because the success of these savings can be attributed to having a simplified registration process, VAT exemptions, and also being open to feedback from pharmaceutical companies on how to improve tender documentation. So alongside all these budget advocacy, state procurement agency, and the ProZorro system, Ukraine also has access or uses pooled procurement via the Global Fund. So just to conclude, I guess what we have learned from our research is that the most successful strategies to adopt kind of lower price of ARVs include pricing strategy, community action, generic competition, national procurement, support from donor funds and international organizations, so having access to that procurement or pooled procurement system. And then 6 would be simplifying the registration process. Now, it's important for me to note that all of the countries that we looked at are at different stages of transitioning away from donor-funded HIV responses, and they've all made varying progress towards procuring ARVs using state funds. But in general, we found that the countries that we've looked at have to continue negotiating prices and procuring ARVs domestically using these 6 strategies we found to be the most successful. But I urge you all to read our final report, which can be found on our website. It is in English and will be in Russian soon, or it is in Russian, but I don't know how you can access that, perhaps through APH. But it goes into much more detail around the mechanisms each country has used, and it's been a very interesting and insightful topic to be a part of. So thank you so much, and I'm open to any questions at the end.
Thank you very much, Aanisah, for the incredible work that you and the team did and for presenting it to us today. So indeed, it is very it is very impressive how we are speaking about really millions of dollars that can be saved in the region to allow for more people actually accessing treatment. And this is how we make 95 a reality in the region. And this is how we can make a transition happen. Thanks a lot for that. You will, all the participants of today's webinar will receive also the Russian version of the presentation made and the English version. And also you will see the link to the report in English and probably in Russian. Thank you very much. And maybe it would be really great to discuss more on why some countries did better, did such dramatic changes in reducing prices, like Kyrgyzstan. There will be time for that at the end of the webinar. Now I'm very pleased to give the floor to Esteban Burrone from Medicine's Patent Pool. This is the organization that has actually made it possible for some of the key medications, generic medications, to enter the markets in EECA and to dramatically reduce the prices there. The mechanism of voluntary licenses has been critical for making this happen. So dear Esteban, would be so great to hear from you on about this mechanism, what it does, how individual countries can benefit, and well, maybe what are some of the things in your pipeline, what are you looking for in future for the great work that you do. Thank you, Esteban, please step in.
Thank you very much, Tetiana. Can you hear me well?
Yes, we can hear you well, and we can see your screen. It is not yet full screen. Yeah, now it is full screen. Yes.
Thank you very much, and thank you for inviting me and Medicine's Patent Pool, and for the opportunity to be here with you. And thank you also for your colleagues who very kindly translated these slides into Russian. And I do apologize that I'm not able to address you all, and I have to address you in English, but hopefully the interpretation will help us, and the translation that was kindly done by colleagues at the Alliance for Public Health. So thank you very much for that. So I wanted to talk a little bit about how the licensing, voluntary licensing for key antiretrovirals, and very much in particular zoom in on dolutegravir, which has been, as the report shows, critical in this whole, as part of the WHO recommended treatments, and has been a critical component of antiretroviral treatment in the region. I do want to perhaps preface by saying that, thanking very much Aanisah for her presentation and for the work on the report, which is a very interesting read, and I definitely recommend it as a very interesting overview of what's been happening in 5 countries in the region. But I do want to say that when I initially saw the report a few weeks back, as often happens when we have limited time, I only read the executive summary to start off, and the one-page summary. And I was quite disappointed, I must say, to see where some of the emphasis was being placed. I mean, from my perspective, you can have very transparent procurement systems, you can have pool procurement, you can have competitive procurement processes, you can have all the support from donors. But if you haven't got the competition among manufacturers that's been possible through the licensing, you wouldn't get the prices that you've seen, or you wouldn't have had that price reduction. And it's only when I dove into the details and started reading the detailed report that this all comes out. So I was a little bit disappointed again in the presentation that was just made, that the central role that the licensing agreement that was negotiated with ViiV Healthcare back in 2014 doesn't come across as being a critical enabler, that without which a lot of the other things would have not been possible. And I do want to highlight the very important role that civil society and community groups have played throughout, both in supporting the licensing, but also in supporting its implementation and ensuring that that many of those critical steps happen. So I did want to make that point to start off with, and I will come back to that in my conclusion. So what is the Medicines Patent Pool? For those of you who are not familiar with us, we're a public health organization and it's based in Switzerland, in Geneva, set up in 2010 by UNITAID to accelerate access to new HIV medicines. Over time, we've expanded to other therapeutic areas. How do we do this? We do this by doing voluntary licensing. What does that mean? Is that we discuss with the owners, with the developers, with the innovators who developed a new treatment, and try to come to an agreement on conditions under which we could have generic manufacturers come in to supply low and middle income countries, or a good number of low and middle income countries. And these licenses enable generic manufacturers to come in many years before the patents expire, and to supply the large volumes that are required, and to do that at prices that are more affordable. In addition to that, the licenses that we have negotiated have also enabled the development of new formulations that may be particularly needed. And here we can bring as an example, and we'll see that later, the combination TLD, which is today the preferred first-line treatment. TLD is a combination that brings together tenofovir, lamivudine, and dolutegravir, and that was developed as a result of the licensing that took place several years back between Medicines Patent Pool and ViiV Healthcare, and that enabled the development of this one pill, once a day regimen that is today being widely used worldwide, and also in the countries in this region. So let me explain to them briefly how it is that, just because sometimes we gloss over, we get lost in some of the complexity around the patents and the licensing piece. So just trying to make it as simple as possible to understand how the licensing can play a critical role in ensuring price reductions and affordability. So this is a very simplified model, but that really came out in a paper a few years ago, and I think kind of nicely shows how once patents expire, you'd usually see the competition coming in for a given product, and when that competition happens and more generic manufacturers coming, you see gradually a price reduction, and that price reduction can result in increased uptake. So more people being able to access as governments can procure high volumes, and that finally results in impact, meaning more people have access to the treatment, and hopefully that having a particularly important impact on health, on improved outcomes, lowering mortality, lowering morbidity. So that's what the role that the coming in of generic manufacturers can play in terms of resulting in price reductions for essential medicines. So when is it that the generic manufacturers can come in? Well, essentially, I think there's three scenarios where generic manufacturers can come in, and you'll see that sort of price reducing competition. The first scenario is if a product is not patented in a given country. So as you probably know, patents are valid in specific countries where they've been granted. If there's no patent in a given country, a generic manufacturer could come in that country, or could make the product. At times, you need to be looking both at the country where the product will be manufactured, as well as the country where the product will be supplied. Patents on any of those two could potentially get in the way. An example I provide here is the hepatitis C treatment sofosbuvir, which is not patented in Egypt, and you see multiple manufacturers of sofosbuvir supplying the Egyptian government the very large hepatitis program in Egypt, and that has enabled millions of people to be treated with products that are very affordable. A second scenario where you would have generic manufacturers come in is when the patents on a given medicine have expired. So an example of that could be lamivudine, which is an old drug, an old HIV medicine, which is still very much used today. It's part of the preferred first-line regimen, but the patents expired back in 2010. So generic manufacturers, of course, could come in any country worldwide for lamivudine because patents have expired. In many cases, they did come in before patent expiry, and that was because of the licenses that were there. So let's get to the licensing, which is the third scenario, where you may have patents in a given country, they have not yet expired. And so how would you get, how would generics be able to come in such a scenario? It's when there are licenses in place, when licenses have been issued. And the example I provide here is the licenses that MPP has negotiated with Pfizer and Merck on the COVID antivirals, for example, and that has enabled generic versions of these antivirals to be developed and to enter the market and to be supplied. And this is very much similar to what happened in relation to a number of HIV medicines that MPP, for which MPP has negotiated licenses over the years. And really coming to the recent years, the most a critical one in this respect has been dolutegravir, and that's why I would really like to, in a moment, focus on that. But just to give you a sense of what is the patent expiry date for a number of medicines that are often considered by this community, we can think of the TB medicine, midaquilin, cabotegravir long-acting, dolutegravir and TLD, lenacapavir, molnupiravir, and nirmatrelvir. And you can see the patent expiry dates for each one of these products. So the point I'm trying to make here is that in countries where patents on these products have been granted, you would not have generic competition until patent expiry, unless licenses are issued. So today, had there not been licenses, you would typically see, dolutegravir, perhaps you wouldn't have, you would most likely not have the generic manufacturers supplying and all those procurement processes in place to enable competition and to enable price reductions. You wouldn't have that until 2026. You wouldn't even have the TLD combination until 2026. But of course, that's not the case because, as we'll be speaking in a minute, licenses have happened. Similarly with cabotegravir long-acting, we have a license agreement with ViiV Healthcare for PrEP, which will enable generic versions to come in before 2031. And for molnupiravir and nirmatrelvir for COVID-19, again, some of those licenses made that possible. Now, in terms of dolutegravir and TLD story, which is central to your analysis for the economic impact, that license was initially negotiated back in April 2014, just a few months after dolutegravir got approval in the US FDA and the European Medicines Agency. That included a number of countries in this region. In 2016, this license was expanded to include 3 important countries in this region: Armenia, Moldova, and Ukraine. That was an important milestone. Among other things, that was the first time that Ukraine was, to the best of my knowledge, that was the first time Ukraine was included in the voluntary license. And that was quite critical because it really enabled Ukraine to transition to dolutegravir, in addition to, of course, the critical role played by civil society, communities, governments, and procurement processes that enabled all that transition to take place. In August 2017, the fixed dose combination should say TLD here, not TLS. So that's a mistake. It's TLD. Was first approved in August 2017, and shortly after, Unitaid, CHAI, UNAIDS, and others negotiated a price of $75 per patient per year for this combination. And the idea was very much to enable countries to transition from efavirenz-based treatments to dolutegravir-based treatments very rapidly and not have to wait many years for the volumes to reach a level in which the prices could be reduced. So those though that negotiation back then, that price negotiation, which was backed by a volume guarantee from the Gates Foundation, was also very important to enable generics to come in immediately with a low price for TLD. In December 2020, we again with ViiV came out with a new license that focused on 4 upper middle income countries. So these were countries that are upper middle income countries. The greater GNI per capita, and that had patents on dolutegravir, and at the time were able to access dolutegravir only from ViiV Healthcare. And we found a way to have these countries to be able to benefit from lower prices through a royalty-based agreement that we struck with ViiV, and I'll talk a little bit more about that. And by June 2023, already 7 million packs had been delivered of treatments to 10 countries for which I collected data, I'll show in a minute. And these are the 10 countries for which I'm showing data, which I think are countries that are represented here, 5 of which were part of your analysis. And as you can see, there's various formulations. It's not just the dolutegravir 50 milligram, but it's the TLD formulation, which I mentioned. It's the dolutegravir pediatric dispersible tablet that is now being scaled up also in some countries. And that again was developed by licensees with the support from ViiV Healthcare, from Unitaid, and from CHAI, that has enabled a new formulation, ideally an ideal formulation in many respects, a dispersible tablet, 10 milligram, and that's been rolled out quite extensively around the world, including recently in this region. And we see that, for example, Ukraine and Moldova have already been significantly transitioned into this as the preferred option for pediatric treatment. We can see the kinds of prices that the Global Fund has negotiated, and I know the Global Fund will be speaking later, so I won't get into this, but these are the kinds of prices that are available for dolutegravir-based treatments in a large number of countries that receive support from the Global Fund, including some in this region. So these are the kinds of prices that could be used using the Global Fund for those who are procuring via Global Fund or similar structures. And finally, the specific agreement I mentioned for 4 countries, but 3 of them in this region, which has also enabled quite significant price reductions. We see price reductions over 70, some cases over 80% for dolutegravir-based treatments following this agreement, and that has enabled some countries to really scale up the use of dolutegravir. Belarus is a good example, with large volumes being procured and a significant majority of people on antiretroviral treatment now on dolutegravir-based treatments. But we're also seeing similar transitions taking place in Kazakhstan and Azerbaijan. And of course, all of that very much also supported by very strong community advocacy and government commitment to make those transitions and to implement this agreement. Now, you will see that the kind of price ranges you'll see in these 3 countries are not equivalent to the kind of prices you're seeing in some of the other countries in the region. And that's an important point to be made. And if you look at the GDP per capita of a country like Kyrgyzstan, who's benefiting from much lower prices, and then you compare that with a country like Kazakhstan, it's over 6 times higher in Kazakhstan. So in some respects, it's not shocking to see countries that are able to benefit from the lowest prices are countries, mostly lower middle income countries, or some of the countries that have lower GDP per capita, whereas some of the countries that are more wealthy are paying more. And that's, but at the same time, what that agreement does is enables these countries to transition to dolutegravir-based treatments in a way that is sustainable and that is enabling significant uptake. So I think this is a really interesting agreement to try and make sure that all the different countries can benefit from access to the generics and for TLD. So I guess my conclusion is that you can have a lot of important work done on the procurement side to improve mechanisms for procurement and to have greater transparency. But unless you have those licenses in place early on, you will not see the kind of competition, the competitive procurement and tendering process that has enabled these massive price reductions. So the licensing has been critical. In a few of the countries, examples mentioned earlier by Aanisah, generic competition was mentioned as a critical enabler. I think it was critical in all of these countries. And the generic competition happened because of those licenses that took place a few years back. So I really think that we need to be very conscious of that, of the critical role that that played, if we want to make sure that we continue to advocate for the policies that can enable us to do similarly for other products in the future. And I do want to stress, to conclude, the critical role, of course, that the community advocacy and civil society advocacy has played at every stage of the process. Thank you very much to all of you, and over back to you, Tetiana.
Thank you very much, Esteban. And indeed, it's impossible to overstate the role that MPP has played in making antiretrovirals, and particularly dolutegravir, available and affordable in these countries. So appreciate your comments and really happy to have you here to also kind of make this very important emphasis in this discussion. Dear colleagues, I would like to encourage you to please do ask questions in the chat or leave them till the end. Some things may seem kind of complicated in terms of licensing processes or approaches, but don't hesitate to ask questions. This is exactly the time to do so. Now we will, previous speakers have mentioned community advocacy, patient advocacy role as being critical in reducing prices, and I'm very happy to invite Sergii Dmytiiev from Health Advocacy Coalition to actually speak about how communities have participated in the processes, and actually what have been the most recent trends on ARV medications pricing in the region. If we compare 2019-2021 with the last year, which been kind of a critical and crisis year from multiple dimensions. So Sergei, please, the floor is yours.
Да, Татьяна, спасибо, коллеги, добрый день.
Yes, Tetiana, thank you, dear colleagues. Thank you, Aanisah and Esteban, for the previous presentation. It really resounds what you were talking about, and I would like to add to what Tetiana has been speaking about, the role of the community in the stages where the community can be quite effective, and where the community should take the initiative to achieve the reduction of prices. I will ask to switch the slide. So the next slide, please. So what are the reasons for the high prices we can see in different regions, regardless of the qualification of the World Bank in terms of above average income or below it? Usually the monopolies create high prices. Monopolies created by a patent, preferences, I'm going to talk more about, or corruption. The patent, I will tell you, that's a document that gives the exclusive right to the intellectual property to the patent holder. And here we need to speak a little bit more about that in the context of the patents and the table that Esteban has showed about what drugs where are the most needed for us and until which year the patents are valid. But in the context even of these questions, the community needs to affect the patent policy of the state in the context of, well, like reforming it. So one of the problems, for example, is that until 2026, dolutegravir is patented. That is, in our countries, until 2026, there can be no registration of the medicine, and this will not allow us to get generic dolutegravir at the beginning of 2027, so it will take time. And so these norms need to be changed, and the communities do that in some countries of our region. The other reason is the monopoly and the market preferences from the state. Quite often we see that some particular state prefers the local manufacturer. Why I have showed this quotation marks? Because mostly they are not manufacturers but distributors that pretend to be manufacturers, and quite often we understand that in the countries that there is legislation that does not allow creating more than 10% of profit margin for medical drugs. So they use Emirates, they use fictive companies to import in our countries the drugs with significantly higher prices. So the preferences are not about manufacturers, but about individual distributors. I will not remind about the prices in Kazakhstan, where they had sort of national manufacturer who was selling the same drug several times more than the regional manufacturers. So these preferences are a huge threat to pricing in the countries and accordingly to the access to treatment. Corruption. Here I will be speaking, I think I will discuss about this question later on specific examples. I have two cases I would like to discuss, something that has already been mentioned before by the previous speakers, but I would like to explain more about that. I would like to tell more about the essence of the problem. The next slide. So this slide shows what Esteban showed like 5 minutes ago. Very specifically, it was the dynamics of the decrease of the prices in the first 10 years because of generics. And the more generics were there, the better was the price and the quality. And if at the beginning of 2000, so it cost 12,000 for a yearly course of RT, then by the end we saw $300 for the course of treatment. The next slide, please. The community decreases the prices. How does that happen? The community conducts some pressure on patent holders. Quite often, and Esteban has mentioned that before, in 2017, Ukraine received access to generic version of dolutegravir, and a lot of time in one or another country, there were these significant actions by brand manufacturers to leave the market and give the access to the generics. Quite often that happened because the NGOs submitted patent oppositions, so like it was in Ukraine. That is, they went to court to have a discussion about the patent with the quite often secondary patent of the patent holders. Those are so-called evergreen patents. You know, when the pharmaceutical manufacturer registers the patent not for the active substance, but for like the ways of use, the formulation. So these secondary patents quite often extend the term of the patent in the countries, and that's probably the main barrier preventing the improving the pricing and participation in the procurement processes, negotiations, and so on, but nomenclature development. But the previous speakers have not mentioned that, but I will speak about that in more detail. The next slide. Yeah, so we are talking today a lot about the patents, about licenses, about the procedure for tendering, the bidding, how it has become transparent in Moldova, in Ukraine, that there is a Prozora system. In some other countries, there are transparent system to ensure access to information about pricing, but unfortunately, quite often corruption, something that I have mentioned before, and the other barriers are below the procurement level. So here the effectiveness of price and reduction is shown by the communities who take part in the processes.
First, this is optimization of the procurement process, as discussed above. This previously, there's international procurement mechanisms that are using by Kyrgyzstan, Kazakhstan, Ukraine, Armenia, and the results are quite positive. At least some corruption factors have been removed from the procurement process. Developing the nomenclature because that's important, because when developing the nomenclature, the selection of products for procurement, mostly the corruption is there. Because if we speak about Ukraine, the situation was actually, I will comment on that, but the situation was the same in Moldova. This is the only drug that is not recommended for first line by WHO. Ritonavir, it took about 65% of all the procurement of ARTs in the countries. So this is about how the nomenclature was developed. Also, there is a collection of needs, and quite often this does not take into account recommendations of WHO. And here it is important for the community to participate in planning with the community, to develop the nomenclature, to develop the collection of needs for the products. And this is before the tender procedure and protocols. Why it is important to have discussions with clinicists in the country on clinical protocols for treatment. This is because not all the countries in the years that we're speaking about promoted the philosophy of WHO, and quite often in first line of treatment, there were a lot of products, protease inhibitors that are often very expensive in the region. So the very procurement was quite bulky, expensive, and there was nothing to optimize. And thus representatives of the community need to build themselves into development of treatment protocols, and there it's possible to see significant price reduction. Next slide. Price reduction mechanisms by the community. What else can be used? This is negotiations. What's negotiations? Negotiations, it's a good example in the region. The Eurasian Community for Access to Treatment, and also representatives of the communities and pharmaceutical companies that collect questions from the regions. They meet producers, generic pharmaceutical producers, branded producers. They determine certain issues and they find solutions. And that is what I could refer to as the negotiation process with the pharmaceutical producers. And also there are representatives of the communities where the procurements are announced. They invite all generic producers to join the tender and submit their applications. It seems to us that actually all generic pharmaceutical producers know about tenders in Kazakhstan, Moldova, Ukraine. And this principle of interacting with pharmaceutical producers proves to be efficient, because all of us understand that the number of competitors determines the price and quality of the product that's going to be sold. Regarding voluntary licenses, thank you, Esteban. What you have done in the region that has resulted in significant price reduction. And of course, well, not everything was perfectly smooth. If we take the example that you mentioned about Kazakhstan and the countries, and thank you for that, now we have voluntary licenses in countries where the income level is upper medium, based on definition of the World Bank, but this limitation of generic pharmaceutical producers to 3 and initial lack of understanding of who is going to supply to Belarus, Kyrgyzstan, and Azerbaijan, that proved that unfortunately in the first year the price of generic products of Hetra company was set higher than it was promised by the brand product producer for dolutegravir a year before. In this sense, I believe that we need to ensure more transparency, more representatives of generic pharma. I understand it does not depend on you, that's a negotiation process, and this is about the VIV, about the brand producer, but this is the experience that we had there. And let's go to the next slide. How the community gets involved and with whom we interact. Let's skip this slide because actually I've explained that. All of these instruments, which price is considered fair. We know University of Liverpool, Dr. Andrew Hill, who back in 2016 said the lowest possible prices. For example, $4 for monthly course of dolutegravir. This is what the countries have: Kyrgyzstan, Moldova, Ukraine, Tajikistan. Prices in EECA region have started to approach what Andrew Hill mentioned 10 years ago. And you can see the prices in Kazakhstan currently. Unfortunately, if we speak about the regions with upper medium income level, and that is Balkans in particular, there we see that access to dolutegravir is very limited due to the price, because prices may go up to $500 per 1 month course treatment, and this can hardly be compared with the prices in Kazakhstan, for example, or in Belarus. Of course, in the Balkans, whether there are plans to expand those licenses and talk to brand product producers, well, this is what should be discussed, can be discussed with Esteban in the context of Balkans. Now let's take some success stories cases. It was mentioned about that, it has been mentioned about how in Ukraine it worked with the e-procurement system, Prozora, and how the state supported that. But here we can express gratitude to the Global Fund. They supported the community in the context of price reduction, and the community suggested this formula 20-50-80 together with the state. They arrived at a compromise with the state. There the state undertook obligation for procurement of the product and for funding of prevention services among key populations. You know, here in Ukraine, it was mostly not so much about Prozora or international procurements. This is about that the community actively got involved into the process of planning with the state, entering the nomenclature groups and developing the procurement cycle and collecting the needs. Together with partners from WHO, PEPFAR USA, the group was set up that developed the strategy to optimize the treatment for these 3 years in Ukraine, and that was something that contributed to adequate order for the products, and WHO recommendations, guidelines are implemented by the country, by the state. And that is something that helped the country saved about $12 million in 2 years, and that was the a success factor, this 20-50-80 formula, where the money was used for prevention, care, and support. Unfortunately, because of the military aggression by the Russian Federation in 2022, the state lost the opportunity to finance these programs, and we are grateful to the Global Fund that they supported with PEPFAR, and now they procure both the products and services. But I know that in 2026, Ukraine is supposed to go back to procurement of the products, and everything that back in 2018 formed the basis for this optimization of pricing will be helpful to prevent putting too much burden on the state budget. You can see the example of lopinavir, ritonavir that used to be prescribed as first line in all countries of the region, $62 per month. It could be reduced to 18, and this was the price offered by generic producers. Despite the difficulty of producing lopinavir, ritonavir. So here, again, in the countries, nobody prescribed zanavir, ritonavir, which was $17. It was not even included into the nomenclature, because in the context of corruption, we have to admit that lopinavir, ritonavir at the price of $62 prevailed. But I believe that that pressure from the community at international conferences and the contesting, appealing against those procedures by communities contributed to that now the countries can procure generic products, but here it is also about registration aspects that needs to include communities, because in a lot of our countries that's a very bureaucratic process, and as a result many countries still buy branded lopinavir, ritonavir, and that's because of the registration process of the products in various countries. Well, I understand that I'm taking a bit more time than allocated.
Sorry to be intervening such great presentation. Could you please be concluding just a couple more minutes? Thank you.
Yes, that will be enough. Thank you, Tetiana. So now, success story of Ukraine. So we have covered this. Let's go to the next slide. I would like to mention the case of Moldova. It has not been mentioned. It was about patents, about the patent reform, about the tender, but we didn't mention the very good case in the framework of SOS project. This is when the community analyzed the nomenclature and collected the needs and determined that dosage of one of the products, tenofovir and sacravin, was developed in particular for the benefit of the branded producers. The community could see that and started negotiations with the state and canceled the tender. And they contacted pharmaceutical producers and paid attention to that tender and requested the generic producers to have access. So for the small country, Moldova, we can see that there the community significantly contributed to the processes, as mentioned before, to $528,000. This is very significant for Moldova as a small country. And let's go to the next slide. And this is the example of how prices for test systems went down. You can see minus 72, 56% after the community analyzed the procurement process, and the pricing for test systems for HIV, and they published these reports. And convey that to the state and journalists. So thus, in a couple of years, there was this significant reduction. And let's proceed with the conclusions. So these are the key areas for advocacy potential. This is what we have to do. We need to coordinate everything that I mentioned and what the previous speakers mentioned. Patents, voluntary licenses. These procedures will not be efficient without involving the community into developing the nomenclature, protocols, collection of needs, and the procurement cycles.
It is important to ensure coordination and working together. Simplification of market authorization mechanisms in the country is what I've mentioned to ensure the competition, removing monopolies, using TRIPS flexibilities in relation to new products, ongoing work to optimize treatment and testing protocols, and expansion of successful experience to the field of diagnostics. And the final slide on the recommendations for donors. Donors need to strengthen investments in community development to increase the ability of communities to develop joint plans with the state. States need to open data for community monitoring and analysis, modify the nomenclature, collection of needs, and protocol discussion groups to ensure community participation. Openness of the data, for example, in Kazakhstan, where even the legislation closes the data on price and on procurement processes, prices of different medications. The communities need to strengthen monitoring, build up the expertise, seek their inclusion in the groups I've mentioned, and change health policies. Thank you very much, Tanya, for your patience. Thank you, dear colleagues, for listening to me, and this is it.
Thank you. Thank you very much for such richness and comprehensiveness of data and for adding more elements to the puzzle, so to say, speaking about community role, but also on preferential pricing, mentioning about corruption and what it can do to increase the prices tremendously, the need of openness of data. Thank you. Thanks a lot. And for bringing the successful examples and seeing how we can monetize those reductions into really millions of dollars. Thanks a lot for that. We can see some hands and also questions in the chat. We will address all those after our next speaker, and I'm very pleased to invite Ganna Bolokhovets from the Global Fund to share the Global Fund activities and maybe plans related to price reductions. It's the biggest donor working on HIV/AIDS in our region, and is not only giving funding for medications and looking that they're used efficiently, but also supporting how to optimize this procurement and establish some of the very important mechanisms such as BAMBO. So Ganna, the floor is yours. Thanks.
Здравствуйте, слышно меня?
You hear me? Yes, great. I will be speaking Russian, if you don't mind. I have analyzed who the participants are, and I see that most of the participants are Russian speakers, and therefore my presentation will be in Russian. Well, actually, for those who don't know me, I'm Ganna Bolokhovets. I work on in the Global Fund, working in the area of medicines for the region. Sergei Esteban has said it all. I have nothing to say now, but just like Esteban, I want to say what's the most important thing in this process. And I think that the most important is not even the role of every organization, but our cooperation, close cooperation, timely cooperation. Why? Because like Sergei has showed, well, basically we can achieve price reduction at every stage of procurement, starting with the choice of the medicines to be procured, and then using the advocacy tool when you already well receive the medicines. But unfortunately, now we don't have a single organization that has an expertise of how to address those barriers with regard to high prices at every stage of the procurement. Therefore, the close cooperation between the donors, civil society, of course, and the ministries of health and the technical agencies such as WHO, big procurement platforms like UNICEF and UNDP, medical patent pool, they are very important, and only this joint cooperation will allow us to achieve the best results. So what is the goal of the GF in this all? You all know very well that we are not a technical agency, unfortunately. We are a fund, so it's not our mandate to achieve the price reduction for treatment of HIV or tuberculosis, but that's a priority for us, nevertheless, because that allows us to expand the coverage with the treatment for people who need it while using the limited resources. And the resources in the EECA region are, well, getting smaller with every next funding cycle of the Global Fund, unfortunately. In the process of price reduction by the Global Fund, we will have three departments: the procurement department for the countries that procure through WAMB platform was using the money of the Global Fund, plus we also have some exclusion in the region. Georgia uses the state budget funding for procurement through WAMB platform, but that's a separate case. I will speak about that in the end of my speech. We also have now got technical department with technical experts, and these technical experts, they also provide their expertise about how the prices can be reduced based on the analysis of the procurement plans that the countries provide every 3 years in their funding applications. And with well, final like beneficiaries, we have and recipients, principal recipients. Our country teams work with them, and we help them to reduce pricing when it's procurement using the state budget funding or the global fund funding. Now let me speak in more detail about every department. So the sourcing support department, as everyone has said before me, this department has a huge procurement capacity, and thanks to that they have a strong leverage. So they, as Sergei has said, can conduct joint negotiations, joint tenders, and a good example is the pediatric antiretrovirals. This department does that together with other organizations such as UNICEF and UNDP. They conduct joint tenders. So joint tenders of these three platforms allow meeting the needs that exist in the countries. Also, they do joint global forecasting and assess general demand. So having this accumulated demand, they can well, exercise some pressure on manufacturers, achieving some discounts and some better conditions. They conduct regular market research. Having this huge procurement capacity, they can impact the innovations. Conducting this market studies, having this data, they can say, yeah, well, can't you start producing this kind of formulation because we have a lack of it on the market? Could you start producing this or that medication? We know that you have this substance. So that's the kind of work that is being done. It also allows reducing the prices. Besides, as Sergei has already shown, the collection of data about the prices and quality plays a huge part, and there is a PQR platform, the Global Fund, and every PR indicates there the prices they use to procure the medicines using the global funding. So these prices are monitored and compared. If there is some high or low price, that's a red flag, and that's looked into in more details. How have they got this low price? What else we need to do to achieve the same price, and so on. So these prices are transparent. Every recipient or principal recipient has the access, or if not, they can demand it to see who buys what at using the global fund funding. Besides that, establishing good relations with manufacturers, long-term contracts allow us to improve those relations and ask for something more than we used to have, for example. So this role can be played by any large international agency, UNDP, UNICEF. We all have comparable prices and comparable conditions, or the national procurement agencies. The countries where this amount is smaller, it will be harder for them to achieve the same good conditions, but the principle is still the same. Now, talking about the technical expert department, that's a new department. We didn't have it before. Now we have these people. They are very proactive, they're very energetic, they're very willing to help the countries. First of all, what they can do, they check the nomenclature, as Sergei has mentioned, and the choice of the medicine. So it's not a secret for anyone that optimization of the treatment leads to improvement of the clinical outcomes and further reduction of costs, both for implementation of the projects and for other activities. Also, it's not a secret that not all of the organizations have switched to DTG in the first line, and that's what the technical experts check. They also look at the potential optimization in the second line for implementation of dolutegravir using the pediatric dolutegravir. I know that not everyone has access to that. Nevertheless, the countries need to switch to it if they can. And some things that we forget quite often, it's procurement drugs in big packs. That is, when the orders are made, we sometimes don't even pay attention to what kind of package is offered, but that's a fact that big packs cost cheaper per tablet than small ones. Also, there is some space for optimization as a part of work of PrEP in the countries where it exists. The technical experts help achieve some better financial optimization. Now, talking about the country teams that work with you directly, we will try to help as much as we can. And for the purpose of advocacy, we organized meetings in Minsk in 2016 and 18, where the pricing for antiretrovirals was one of the big directions of works, and all the experts and technical agencies were invited, and civil society and the medical patent pool and PharmaLeaf was there, and they conducted those meetings that ended to with getting the voluntary licenses, and now they're planning the third meeting of this same nature with the same goal to discuss the post-COVID challenges, to discuss other challenges in the region that have appeared, and continue discussing the important things. Besides the regional grants, there are 3 cycles of the regional grants, at least, have been dedicated in part to the reduction of ART pricing. Close work with medical patent pool, everyone has already mentioned that. Besides, we help some countries to change their legislation to get access to international procurement. Armenia is a good example of that. They changed their legislation and to procure antiretrovirals and to tuberculosis medicines and diagnostical means, they have special bylaws that allow them to go directly to international organizations. Belarus is also interested. We've been having this dialogue for some years, they got changes in the Ministry of Health, and they say that they are open and continue to be interested. We also analyze with the country teams the plans for procurement every 3 years or often if it's needed. We can support the countries in updating the national guidelines. We can help them with market authorization of the medicines. We just discussed it months ago with the Tajikistan Minister of Health that we will be supporting the registration of antiretrovirals in that country, and we can provide support to the national procurement agencies, and it worked like that in Ukraine. For several years, we provided financial support to the national procurement agency from the grant of the Global Fund. And I was asked to provide some example, and I would like to share the example of Georgia. That's a bit outdated now. Of course, it's dated back 2014, but that's a comprehensive one, and it shows how every process, stage of the procurement process may lead to optimization of the end price. And in 2014, the state decided to fund antiretrovirals procurement, and they decided that this funding would be continued through the GFPR.
Everybody knew that they have great capacity and nothing parallel, no parallel structures were required. The situation has not changed. We understand that maybe this is not the most sustainable option, but this option works, and everybody seems to be quite happy with it. So evaluation was held, and by the country team of Global Fund and by the WHO expert center, and the decision was made that the current regimens were very expensive and the prices were not competitive. Quality ARVs were not highly accessible or affordable because this is quite a small country and low volumes, and then the procurement systems implied certain risks and was not reasonable, and unregistered products could be imported upon a special permit, and the legislation has not been revised. WHO reduced the number of regimens from 44 to 12, and that resulted in reduction of the cost for first-line treatment from $1 million to $300,000. The decision was made that procurements would be made simultaneously for the Global Fund and for the state, and in order to increase the capacity and thus reduce the price, to try and reduce the price, the non-competition permit was received. Branded products, unfortunately, were supplied if the product was protected by a patent, and this is still relevant, but in Georgia, only the third-line drugs are patented. And this is not about huge financial costs. And one supply chain for all antivirals, both funded by the Global Fund and with state funding. Thus, the total procurement reduced from 1.7 million to 900,000 euros. Thank you for your attention, and thank you for this important meeting and for the opportunity to speak. And let me reiterate that only our joint work will make it possible for us to achieve maximum result in this aspect. And Sergei recommended to donors to enhance the capacity of civil society. We are ready to do that, and let's do that together. Thank you.
Thank you very much, Ganna, and thanks for kind of summarizing, bringing everyone on board in terms of the different roles that different agencies can play, both on working on clinical protocols, streamlining procurement, and illustrating it with a brilliant example of Georgia. Thanks a lot. So now we are switching to discussion. We have about 12 minutes left. So there are 3 hands and 1 question in the chat. Maybe I'll start with asking Aybar Sultan Gazir. If you are giving a comment, just give a comment. If you are asking a question to someone, indicate to whom the question is. So Aybar, please take the floor.
Да, здравствуйте большое.
Yes, hello, and thank you. Thank you all for this review. It is important, and it so this is a high-profile publication, and Esteban said, mentioned some emphasis, right? I believe that everyone wants to put their logo there and to state their involvement. In Kyrgyzstan, in this year, we reduced the price even further, and now it is about 60 or a bit more dollars per 1 year TLD. Course, this is due to joint advocacy, regional project, all of that is happening. I don't know if the price can go even lower, but speaking about the emphasis, let me mention that here everybody mentioned adequately that this is about comprehensive joint work. So in the report, we keep seeing coalition for budget advocacy for our country. I don't quite understand why that's mentioned. I mean that the coalition, right, the coalition participated in allocation of funds, but not in cost reduction. This is something that I wanted to emphasize so that you corrected that in the report. Unfortunately, I have not yet read the English version because it's easier for me to wait while it is translated into Russian to understand everything. Comprehensive work implied that starting from revision of patents that has been happening for a while and proceeding with monitoring of procurement, as Sergii mentioned, negotiations with pharmaceutical companies and that are ongoing, and expanding competition, as Esteban mentioned. Due to that, there are a lot of products, several types of products in the market of the drugs. And we revised the laws that facilitate registration. Last year, for example, in procurement, companies could participate who are not even registered in the market. They could be registered after they won the competitions. These are the processes that took place. And well, this work needs to be continued because businesses look for ways to increase their profit and to increase costs. For example, now the Eurasian policy results in that, for example, in our market, there were 9 types or Sofosbuvir, the sphere, and so products for treatment of hepatitis C were registered, and their 5-year registration term has expired, and now we need to comply with new rules, and only 2 products out of 9 will be available in the market. And this is what's happening this year. Same may happen to ARVs. And we see the attempts to promote TRIPS Plus legislation, which makes it harder. This is about intellectual IP, and well, we have to advocate so that they didn't do that. And they tried to revise the law on public procurement so that it were less transparent, and then corruption risks would go up. All of this, despite the a lot of success, this is a challenge, and we have to work on that. And thank you so much. This report is very important.
Thank you very much, Aybar, for also bringing in country perspective and also sharing some of the kind of challenges and mentioning that it has to be ongoing work. There is a question in the chat which I would like to address to Sergii Dmytiiev, which is about who community is and how you can actually get them mobilized to work on ARV price reduction. Sergei, if you don't mind, would you answer this one?
Right, thank you, Tetiana. Who the communities are? Well, Anton Basenko is here, and well, the community, that's about the people who get organized in order to feel safe, in order to have access to treatment and to be protected against discrimination and stigmatization, if that's the question. And let me explain a little bit what I said. Involvement of communities into planning together with the state. Well, in every country, they develop nomenclature, they collect needs for procurement. Nomenclature, this is the list of products that are going to be procured, or test systems. And thus needs are assessed, and they are more or less the same in countries of the region. So in these groups where there is no involvement of the community, I recommend you to participate in those groups, to come up with some suggestions. Even if you are not physically present at sessions of the groups, it's always possible to influence decision-making on nomenclature, on collection of needs, with based on the mechanism of public hearing. So there is the principle of public hearing, where you can submit your communities can submit their proposals. And if I get your question right, this is my answer. In many countries, communities do play a role in decision making and planning, but often it's not enough. And my message to the state was to open up these groups, and a message to communities to enter the groups. And the examples that we have from cases of Moldova or Ukraine, Kyrgyzstan, that's an example of that.
Thank you very much, Sergei, for bringing an elaborate answer. A hand from Damir Lalicic. Please, please, Damir, ask a question or make a comment.
Thank you, Tanya. I'm coming from Southeast Europe RCN, and we covered this Balkan region. I would like to thanks Aanisah, Esteban, Sergei, and Ganna for the excellent presentation and successful experience from the countries of the region. And beyond that, we heard today, and which are an inspiration for us to continue our efforts. And the fact is that for some countries from our region, we need more time, and we hope that we will continue with our cooperation and this issue in order to achieve the results that everyone needs in our region, but also beyond. Thank you, Tanya.
Yeah, thank you very much, Damir. Indeed, many speakers have pointed about the high cost of ARVs in Southeastern Europe and the way that still needs to be taken. So thank you for having it on the agenda. Anton, please, the floor is yours.
Hello, Anton Basenko, European Group for AIDS Treatment, the community, as mentioned and discussed. So, first of all, let me express gratitude for this very timely and profound webinar. And of course, the presentations have been very interesting, but the discussion takes place in rather in the economic context and from the point of view of the financial aspect, price reduction. But we understand that price reduction would not be possible without, so it cannot happen endlessly. And of course, we should not it should not compromise the quality of the products. And since I represent community of people using drugs, and I believe that you know the case of Ukraine for OST drugs, when there was the transition from procurements by the Global Fund to public procurement, and the very system that actually did not take into account client satisfaction criterion, but rather focused on decision-making based on who offers the lowest price. Well, it's clear that this kind of reduction could only happen with compromised quality of the product, and we had one of cases with an OST product where we discovered the discrepancy from quality requirements. So I have a question to Sergei, maybe Esteban can add to that. To what extent in the situation in the context of the mechanisms for price reduction that we're discussing today, that have been presented, what are the recommended safeguards to ensure that we do not get lower quality of the products? Another example from Ukraine, Ganna mentioned larger boxes, and Ukrainians who undergo therapy, they know that TLD for 3 months in 3 months dose is now obtained, but maybe it is subjective. But after the previous generic producers, it was very difficult to take it. It was it had quite a significant impact on intestines, etc. So maybe it was about quality, not only in the context of that it became cheaper because the dose is because the amount is bigger, and maybe there were some technological issues. And also at these webinars, it would be good to see.
Sorry to be breaking as we are running out of time.
Right, this is just last statement, that it would be good to see here representatives of state services controlling medical products.
Thank you very much. I would like to invite Esteban to give a comment and response, and then Nurali, and we will be closing. Please excuse, we are running out of time. Thanks. Esteban, please.
Yes, just on the point mentioned by Anton around quality, I think that's a really important one. And what I would like to stress is that all the manufacturers who are making dolutegravir or TLD with a license from Medicines Patent Pool all need to have approval from the WHO qualification or from the US FDA, in addition to now local regulatory approval and regulatory approval in the country of manufacture, and all that is monitored quite carefully. I think that's definitely an important point, and one that is very much part of our work to ensure that is respected by all the manufacturers. I would say that if there are concerns ever from communities or others around the quality of the products that are being procured and that are licensed by a Medicines Patent Pool, I would ask people to flag that, to let us know, because it's always important to try and intervene as soon as possible if there were any concerns around the quality of any of the products. Thank you.
Thank you very much. And last comment, Nurali, please. Kazakhstan has been mentioned multiple times, so I imagine you would have some reactions.
Yes, thank you, dear colleagues. People have been speaking a lot about Kazakhstan, about the local manufacturer and so on. But again, after our activities and the MP's request, the local manufacturer stopped producing ART, and thank God, actually, because its price was overpriced by a factor of 30. So 940 tenge per one tablet, while generics cost 36 tenge per tablet. So currently, just recently we've received the approval from the Ministry of Health to procure TLD, 1.9 billion tenge, it's $4.5 million, and now after the meeting that we had Kazakh British Business Forum about the mining industry of Kazakhstan, and at the time also our council will have a meeting with the manufacturer to reduce the amount of royalty, because we were proposed through UNICEF to buy it at $32, but you must not forget about the margin profit margin added by the single distributor, the transportation costs, and so on. So, well, that's what I wanted to say briefly. Thank you. Yeah, and you know, talking about Kazakhstan, I would add one more thing. You see, 80% of our patients, they receive 2 schemes, and altogether we have 36 schemes. That we have children from Chimkent who receive branded drugs. We buy it for some small amount of people. We have some adults with individual tolerance problems, so Kirexa, Complera, things like that, we buy them using significant amounts of money for a small number of people, so small scopes are always more expensive, and now we are willing to work on the optimization of the schemes of regimens of treatment. That's going to reduce the prices. Thanks.
Thank you. Yes, thank you. Thank you very much, Nurali, from the country perspective. Dear all, we are out of time, so I will be closing our meeting now. I would like to thank Economist Impact for making such a structural analysis and looking into prices on ARVs in the region more systematically. It generated a great discussion. Thanks a lot for participating, for MPP Health Advocacy Coalition Global Fund, and all participants. It's been a very rich, interesting, important and timely discussion, because indeed, while there has been good progress achieved with ARVs, well, there is still a way to go in Southeast Europe, in some of the upper middle income countries. But also there are emerging issues such as prices for HIV diagnostics that was brought up by some of you, or prices for opiate substitution treatment, for prevention medications, CAB-LA. So way to go. Thank you very much, but we feel ourselves well equipped and a strong partnership. Thank you for the webinar. Thank you for your time, and look forward for the next interesting discussions.
Thank you, Tanya.
Thank you.
Bye.